Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Our topic for today is how to improve bone health and prevent fractures with Dr. Keith McCormick. Osteoporosis, according to the International Osteoporosis Foundation, literally means porous bone. It's a disease in which the density and the quality of the bone are reduced. As bones become more porous and fragile, the risk of fracture is greatly increased. The loss of bone often occurs silently and progressively, and there may be no symptoms until the first fracture occurs. Osteoporotic fractures can lead to significant decrease in quality of life, with a significant increase in morbidity, mortality, and disability. Over 50% of postmenopausal white women will have an osteoporotic-related fracture, and only 33% of senior women who have a hip fracture will be able to return to independent living. In white men, the risk of an osteoporotic fracture is about 20%, and the one-year mortality in men who have a hip fracture is significantly higher than that of women. Women sustaining a hip fracture have a 5-fold increase, and men almost an 8-fold increase in relative likelihood of death within the first 3 months. Dr. Keith McCormick is a doctor of chiropractic in Belchertown, Massachusetts, who has come to specialize on consulting with patients about their bone health. He has written 2 books on this topic, including The Whole Body Approach to Osteoporosis, published in 2009, and his new book, Great Bones, Taking Control of Your Osteoporosis, published last year, is by far the most comprehensive book on the topic, and I now consider it a crucial reference guide for treating patients with bone loss. So Dr. McCormicks, thank you so much for joining us.
Thanks an awful lot for inviting me on your show.
Absolutely. So perhaps you can tell us a little bit about your story for our viewers who haven't heard from you before.
Well, I'm an athlete, and a long time ago, when I was 45 years old, I was just doing a run workout, and my hips started hurting a lot, and I couldn't finish the run workout, and the pain never went away, and so I ended up getting X-rays and MRI and everything, and finally got a bone density, and come to find out that I had really severe osteoporosis. And then over the next 5 years, I had a lot of fractures, just from not doing very much at all. Just even leaning up against something, I could break a rib or something. So it was kind of devastating, to say the least. I was only 45 years old, and I hadn't really had major traumas before. So it just kind of, to me, came out of the blue. And for that reason, I talked to 5 different endocrinologists. Everybody just wanted to put me on drugs. And I said, boy, I got to figure this out myself. And so I just immersed myself in the study of osteoporosis and figured it out. And now I work with patients, other people, to help them too.
I have to say, my own personal experience, I'm also passionate about this topic because last Halloween, I fell and fractured my hip, had surgery the next day. After 4 months, was diagnosed as a non-union because there was a gap between the bones after the surgery. And it was recommended to me to get another surgery, take the hardware out and start all over. And I was not wanting to do that. So I figured out a way to get my non-union to heal by way of using a ultrasound bone stimulator, taking daily injections of Forteo and human growth hormone for 5 months, and got it to heal. So that's my own personal story about this topic.
That's a full immersion of learning how to deal with an issue.
Yes. And I have spent quite a bit of time reading in the last year about bone health as well. So,
and that's what you really have to do, to be honest, exactly what you did. And that's exactly what I did, and I, like I said, I work with people every day, and I think they're incredibly disappointed when they go see a specialist in osteoporosis, and the person sits down with them for 5 minutes and says, here's your drug list, choose one, and then they're out the door. And that's why I wrote my book, Great Bones, because I wanted to educate people to say, not only that this is a way more complicated issue, this disease process, than it's given, credit for. This is not just about calcium and taking vitamin D. It's way more complex. And so I wrote the book so people could understand that and say that, and not only understand that more, but have a language, have an understanding that when they do go to see their medical doctor or an endocrinologist or rheumatologist or whoever that specialist is, that they'll be able to have a much better, productive conversation with them because they know the language, they know the ins and outs of bone physiology, and it will just have a better outcome.
Absolutely. It's way more complicated than just take this drug, or even in a functional medicine world, just take this calcium and vitamin D supplement. There's a lot of detail into understanding the different types of bone loss, how to figure out what's going on in more detail, testing that's not normally done, and a way to understand what's going on, and then being able to strategize to use a range of diet, lifestyle, nutraceuticals, and then sometimes medications when necessary.
And that is incredibly important, what you just said about the strategizing. You do, because there's so many ins and outs to this thing. You do have to get plans but figuring out different ways to approach it, but also be ready to change those plans if you come up against something that's not improving. But that's why you're always analyzing, always trying to figure out through lab tests and bone densities what's going on, and then figure out a plan, but be ready to change that plan if what you've decided upon isn't working.
I got to say, there's very few people like yourself going into the depth of analysis of understanding this condition. It's not being done very often.
No, unfortunately, it's not. But we need to change things.
Yes, absolutely. So let's start talking about testing for bone health, and then also go into all the bone biomarkers that we need to look at for being able to understand what's going on.
Well, the first thing people need to do is get a bone density. And a lot of times doctors will not even order a bone density for somebody until they either, for a woman, reach 55 or 60, which is really terrible, or for a male, they might not ever order a bone density. So I really recommend to people that they ask their doctor, even at age 45 or 50, if they could schedule a bone density. So that's the first thing. A bone density it's non-invasive. It takes about 10 minutes to have it done. There's minimal radiation. They're pretty good. There's some problems with them as far as accuracy, but it's the best we really have right now. And so that's the first step, getting a bone density and figuring out exactly if you do have a problem and how big of a problem that is.
And for the clinician, you go into really good detail about how to read the bone densitometer report. And it's really important as a clinician that you not just get the summary of what the T-score and maybe the Z-score is, but you get the full report with the diagram showing the part of the spine and the hip that they looked at. And you mentioned in your book that 90% of the reports have at least one error, and like 40% of the errors are really significant.
Significant, yes. And that's exactly right. You have to get the printout. It's called the bone density printout, not the report. So the report is just from the radiologist, and that's just a very brief 1 or 2 page report that just gives the bone density T-score and Z-score, and that's it. But yes, you have to get the full printout. It's usually about 4 pages, has thumbnail pictures of the hip and the spine on it, and the forearm if that was done. But it gives a lot of different information that's way beyond just the T-score and the Z-score. And as you mentioned, in chapter 5 of my book, I show some of the things that are pretty common mistakes, and even the layperson can look at those things that I bring up in the book, and then they look at their own bone density if they have that bone density printout, and they can say, "Wow, was this done right, or was this done wrong, or this doesn't look right now," and then they can bring that up with their doctor.
Yeah, sometimes they don't collimate exactly which part of the spine they're looking at. You show a couple of diagrams where they're supposed to be looking at L1 and L5, and then instead they're looking at T12 to L4. And then the second time they did it the right way, and the first time they didn't, so you can't compare those. If the patient has severe osteoarthritis, or they have scoliosis, or they have you could have a compression fracture that's not severe that gets missed. All these things will affect the amount of bone density.
And you can't tell that if you just get the radiologist report without the DEXA printout.
Right. And then if the patient needs to be positioned in the machine the right way.
And that's a hard thing to really correct, because, it's the technician that's doing it. And you, the layperson, you don't really understand that, the feet have to be turned in a certain amount. So that's a hard thing to really correct.
Right. But the feet are supposed to be 15 degrees internally rotated, right?
Yes. And they should put you on this little foam a little foam block and hold your feet against that foam block. And then it's done the same way, patient after patient after patient.
Right.
It needs to be, consistent in the way that the technician does this. The problem is there's lots of different technicians at each hospital, and they do them a little bit different each time.
And if they do it on a different machine, if they have multiple machines, that can affect the results too.
Yep. Yes.
And then in addition to getting the DEXA, you also need to get the trabecular bone score if that's available.
If that's available, that's not available in most hospitals, but if it is, the patient has to ask their doctor who did the prescription to put on there, you want a bone density and the TBS and the trabecular bone score. So I encourage people to call around, see what's available at that hospital, and you might have to call up some other hospital and say, "Can I speak to radiology?" And then when you get to radiology, say, "Do you have TBS or trabecular bone score capability with your bone density exam?" And that's the way to ask it. And sometimes you might have to call 5 different hospitals before you find one, but they are out there. And yes, that TBS gives you a quality indices of that bone density. So the TBS is a way it's a computer analysis of the bone density itself. It's not actually another test, and that's why that TBS has to be coordinated with that DEXA machine. So you couldn't take your bone density from one hospital and then go to a different hospital that has TBS and have them analyze that bone density. You can't do that. So you have to have that bone density done at a place where they do actually have the TBS computer program attached to the bone density itself.
So just out of curiosity, by the way, where I am in Los Angeles, in Santa Monica, very close at St. John's Tower Imaging, they offer the trabecular bone score. So I've been having patients get it. But let's say it doesn't get ordered and they get a DEXA at that facility. Can you call up and then add in the TBS if they have the software?
Yes, because it can be done retroactively, yes.
Okay. And that gives you information about the quality of the bone, which significantly can affect the fracture risk, correct?
So inside, in the inner aspect of bone is trabecula. It's kind of like the inside of an airplane wing, or it's the honeycomb area, that struts and bars that give the airplane wing and your bones strength, but make it light. And if those little struts and bars are not connected, and those struts and bars are called trabecula, if they're not connected, if they're disconnected, if they're broken inside, then it doesn't give the bone any strength. I don't care how thick the trabecular are, if they're disconnected, the strength isn't there. So that's what this is doing. It's the trabecular bone score. It's the score of how many of these trabecular are connected or disconnected. And the more you have disconnected, the worse the score is, and the higher the person's fracture risk is.
Okay. So let's talk about some of the most important lab tests, starting with the bone turnover markers.
So lab testing is crucial for trying to figure out why a person has bone loss to begin with. It's also crucial for being able to follow that person and their progress. They're either good or bad. So the most important are what's called the bone turnover markers, and it's the bone resorption and bone formation markers. So the bone resorption markers, the one I use mostly is C-telopeptide, or CTX. Some doctors like the NTX, and you can get NTX or N-telopeptide as a urine or as through blood. Blood is the better way to go, or a serum. So the serum NTX you can get, but I like the blood CTX the most. So that's your bone resorption marker, or an indices of how much activity the osteoclasts are having. So if the osteoclasts, they're the cells that break down bone, if they're really ramped up and cranking and breaking down way too much bone than they should be doing, that number will be high. And the higher that number is, not only says the faster their bone loss is, but it's actually increases their risk. So the higher that CTX is there increases the risk for fracture.
And what do you consider a high number?
Anything about around 400, a person's probably losing bone. I mean, I've seen people lose bone at 350, at 450, but as a general statement, around 375 to 400. If it's over that, they're probably losing some bone. And
can that number be too low?
Yeah, I think so. Typically not if a person's not on a medication, but you're usually not going to see somebody lower than 250 or so unless they're on a medication. The bisphosphonates and Prolia, and we'll get to those in the future, they're the anti-resorptive drugs, and they can really bring that CTX down to 50 or lower, and that's okay to have for a year, but it's not okay to have for 5 years because it makes your bones really old and more brittle. The second marker is the bone formation marker, and there's two major ones for that, and that's osteocalcin, but doesn't really, it's not that accurate, so I don't use that one much at all. The one I use is called P1NP, or procollagen type 1 N-terminal propeptide, and that is an indices of osteoblastic activity, how much activity that they're doing. They're the cells that form bone. So there's three bone cells: the osteoclast, that tear down bone; the osteoblast, that form bone; and then the osteocytes. And the osteocytes kind of run the whole show. They kind of organize things, and they're the general managers of the whole bone remodeling system. So we don't really measure their activity. We just measure the osteocytes, the osteoclast with the CTX, and the osteoblast with the P1NP.
And you also note, I think, in your book that it's important when you do the CTX test that you test it in the morning, and that you not have taken biotin or collagen in the last day or two.
That is crucial for the accuracy of this test. It's worse to get a test and do it incorrectly and get a bogus number than to not do it at all. So yes, if anybody's asking their doctor for a CTX and P1NP, they need to be done fasting. They need to be done first thing in the morning, as you recommended, and then stop all supplemental biotin and collagen for 48 hours before. The P1NP is not as finicky of a test, but the C-telopeptide is incredibly finicky. You have to do it really exactly right to get a good number.
And is this a high dosage of biotin, or even the amount of biotin that's in a multi?
They say 10 milligrams, but I've seen it with 3 milligrams change a person. And I recommend 48 hours, but in truth, you could probably, it really probably only has to be 12 or 24 hours, but better to be safe and not take it for 48 hours.
Okay. So those are really important tests to gauge where you're at, how well you're doing, whether the type of bone loss, if you do have bone loss, is more related to turnover as opposed to anabolic activity. People think that bone loss is just because the osteoclasts are, breaking down too much bone, but it might be because the osteoblasts are really not doing their job too. And when we talk about the bisphosphonate drugs, the anti-resorptive drugs that are given, this is a really important part of the diagnosis and the figuring out what we're going to do for this person. Because if that person has a baseline CTX before they take any medication or nutrition changes, supplements or anything, if their baseline CTX is already low and their P1NP is really low, they have a low bone turnover osteoporosis, taking an anti-resorptive is not going to help them that much.
So it really matters to do these bone turnover markers first before any treatment is taken.
This is really what we call personalized, individualized medicine. And, in conventional medicine, they would say, well, that drug just didn't work. No, that drug was not going to work for you in your specific condition.
Right. Yeah.
Um,
and the other thing I want to say is, and there's other lab tests too, besides the turnover markers, that are really important to make sure that there's not something else going on, like hypophosphatasia or diabetes, or there's many different disorders that can cause a person to have
parathyroid problems, thyroid problems.
And these things have to be ruled out, because you can't just say, oh, you have low bone density, here's your drug. No, we have to rule these things out, like you said, with for the comprehensive metabolic profile, CBC. They'll tell us what a person's blood level of calcium is. Getting a 24-hour urine calcium to see if they're losing calcium in their urine. Get a PTH.
Do you do the 24-hour urine calcium on all your patients, or
99% of them? Yeah.
Okay.
Yeah. If they don't have huge bone loss and they're 60 years old and their bone density is negative 1.5, then I probably wouldn't, but almost everybody else I would.
And then how does that affect the way you treat the patient?
Well, if it's high, most medical doctors would give them a medication to decrease that calcium loss through their urine. But the problem with those meds is they can also increase their loss of, they might decrease the calcium loss in the urine, but they might increase the loss of some of the other trace minerals. And it really can change a person's hemodynamics of their blood and cause dizziness.
What kind of medication blocks the calcium loss?
Well, you can have hydrochlorothiazides.
Diuretics?
Diuretics, right. And these can, like I said, they can cause dizziness in people. And you don't want dizziness, because dizziness causes people to fall. And the number one reason why people break something is because they fall. They also don't really work that well past maybe 2 years or so. Then they lose their effectiveness. So they're just, sometimes patients need a hydrochlorothiazide, a diuretic, but most of the time they don't. And speaking of that test, the 24-hour urine calcium, it's really important to not be taking high doses of supplemental calcium when you do that test. When they figured out the reference range for the 24-hour, they didn't pick a lot of people from, in the world who were taking supplemental calcium. They were making this reference range from people who were just on a standard American diet. That's the reference range it comes from. So you wouldn't want to now be taking 1,000 milligrams of calcium while you're collecting that urine, because that calcium is going to spill over into the urine, and now it's going to look like you have high loss of calcium in your urine, which is not true. So do the 24-hour urine calcium just from what your regular diet is. And if your diet includes dairy products, that's okay. It's whatever you eat regularly, but just stop the supplemental calcium.
Okay. What are some of the other important biomarkers you like to test for? I know you like to look at gluten sensitivity.
Right. So the gluten is one of them. So gluten sensitivity or celiac disease, a person can have actually where they're so sensitive to gluten that they have this disorder called celiac disease. And that can cause them to have less absorption of their nutrients from their intestinal tract. But people can also have just gluten sensitivity where they don't really have celiac disease, but that gluten sensitivity can increase your antibodies to gluten or increase your immune system activity. And when the immune system is ramped up because of gluten, it also ramps up osteoclastic activity. And the reason why is because osteoclasts are a form of a white blood cell. They're kind of really related to the immune system. And any raise of immunological activity raises these signaling molecules called cytokines, pro-inflammatory cytokines, interleukin 1, interleukin 6, tumor necrosis factor. And these, when they are released by the body, the osteocytes hear that, they see that, they smell those cytokines, and they say, oh, I'm getting all excited. And they have one response when they get excited, and that's to eat up bone. So if you can calm down the immune system for whatever that reason is, and the gluten is one way, and it's not that everybody needs to be gluten-free, that's not true. But if you are sensitive to gluten, even if you're not celiac, but if you're sensitive to gluten, and you can tell that by the anti-gliadin antibodies, IgA and IgG, then you should stop gluten. The one test that
do you run one of those sophisticated gluten panels like the Cyrex Array 4 or the Wheat Zoomer?
I think those are really, really good. I typically don't run those, but I run anti-tissue transglutaminase IgA, a total IgA, and an anti-gliadin or deamidated antibodies IgA and IgG. They're the 4 tests that I run. But yes, if a person has major bone loss and we suspect, something else going on and all those markers come back, either I'll just say, listen, you got to go gluten-free, or we test for do a wheat zoomer or something like that. Yeah.
Okay.
Another one is parathyroid hormone, because if that serum calcium in the comprehensive metabolic profile, if that's high, 10.1, 10.2, I would always get a parathyroid hormone, because they might have a benign parathyroid tumor that's causing their bone loss. I mentioned before a condition called hypophosphatasia, and that if a person's
alkaline, so that's low phosphorus?
Alkaline phosphatase, right? And that's way more common than people would really understand. And that can cause not only lower bone density, but an increased fracture risk. I had a patient the other day, and she had hypophosphatasia, and she was put on Prolia. And we'll talk about Prolia in the future, in a couple of minutes. But Prolia is an anti-resorptive, and it didn't work on her. And the reason why it didn't work was because the alkaline phosphatase is so low. She's not having bone turnover. Alkaline phosphatase is from the osteoblast, so her whole bone turnover wasn't high. She didn't need an anti-resorptive, and that's why the Prolia just did not work at all. So
what does the low alkaline phosphatase mean? What is exactly are we talking about?
The osteoblasts they release this alkaline phosphatase, and that's one of the steps that they need to do to form bone.
Okay.
And if a person is not capable of producing that alkaline phosphatase, then their osteoblasts are not going to build.
Okay.
Build the bone.
It's an indication that the osteoblasts are not working effectively to create new bone.
That's right. And so the osteoblasts and the osteoclasts talk to each other. If there's no osteoblastic activity, then they can't really talk to the osteoclasts.
Right.
Her whole bone remodeling, and I've probably had at least 10 people now with this. All their bone remodeling is just tamped down. It's not happening. So they're not having increased.
What causes that?
That's a genetic issue.
Okay.
Genetic disorder. And you can get genetic testing for that. But what's the problem is, because doctors miss that, and then they just reflexively see, oh, this person has low bone density, here's your bisphosphonated, here's your Prolia or something, and they don't diagnose them properly, they can actually hurt that person by giving these medications.
And you pick that up by having low alkaline phosphatase.
Right.
So for that type of patient, an anabolic drug is going to be more effective to stimulate the osteoblasts.
Way better. Yeah, way more.
You talk about the importance of healthy lipids and the ability to have healthy red blood cells and blood flow being a factor.
So inside your bone, there's blood vessels, and those blood vessels carry in nutrients, carry in oxygen, and that's the way the osteoblasts and the osteoclasts and the osteocytes can survive through this nutrition. So if you have arteriosclerosis and you have less poor vascular supply of blood into an area, you're going to have bone loss. And so, yes, you need to test, not only just do a lipid panel for cholesterol and triglycerides and stuff. If they have high triglycerides, maybe they have non-alcoholic fatty liver disease that can also contribute to bone loss. Maybe they have high cholesterol and high LDLs cholesterol. If they have high LDL cholesterol, that can cause an increase in what's called PPAR gamma, and PPAR gamma directly stimulates the osteoclast to break down bone. So you would need to work with that person's cholesterol and LDL to bring that down, to help bring the PPAR gamma down, to help bring down the osteoclastic activity. So the lipids are really important.
Homocysteine, I know, I read in your book, is an important factor.
So homocysteine is a metabolite from protein. So every time you eat protein, and specifically the amino acid methionine, it's broken down into homocysteine. Well, your body has enzymes to either reconvert that homocysteine back into methionine, use that homocysteine as an energy source, or just get rid of it somehow. But it's kind of like a poison in our body. So we need to get rid of that homocysteine. It not only isn't good for your heart, it's not good for your bones. It makes those cross-links in collagen molecules really stiff and hard. And we want your collagen to be nice and flexible. So a homocysteine makes those cross-links really stiff. Anything above like an 8 or 9 for the homocysteine, then you're starting to affect the bone quality of person. So research shows that if we have a normal of 8 for homocysteine, we'll say, if a person has a 15, they might have a 2 or 2.5 times risk for fracture. And that's because of a collagen issue with that. So yeah, that's one of the tests I almost always do is a homocysteine.
And we know by using methylated B vitamins, trimethylglycine, we can lower homocysteine.
Yeah, it's pretty easy to, what you're doing with these vitamin Bs and trimethylglycine and serine and things is you're pushing that enzyme, those enzymes to do their job. You're not fixing anything. You're just pushing them to do their job. And then it really works to do that. Yeah.
Right. Vitamin D, super important, right?
Super important. I usually recommend 40 to 60 nanograms per ml. I'm not one of these people who says you should do 80, 90, 100. I think it's easy to get toxic on that. And I think it's not good for your bones when you get up to 80, 90, 100. So, but 40 to 60 nanograms per ml. And that might be that you need to be 1,000 IUs of vitamin D a day. It might mean you need to do 3,000 or 5,000 or 7,000. Some people don't need any, depending on where you live, depending on what your system is doing. But that's why you don't just tell somebody, take 3,000. You do a blood test. You see where they're at. You usually do them. I usually like to do the blood test in March because that's the lowest that they're going to be in the year because there's less sun, at least up in here in New England where I live. And if they're, let's say they're at 20, well, you start them off with maybe 3,000 or 4,000, then test them 3 months, 4 months later. And if it's up to 30, well, that's not enough. You might have to go up to 5,000. But, we test and then we change what we're going to do. Then we test and we change what we're going to do. But it's all by the book. It's all looking at labs and figuring it out.
Personalized, individualized care. I've really been enjoying this discussion, but I just want to take a few minutes to tell you about a product that I'm very excited about. Imagine a device that can help you manage stress, improve your sleep, and boost your focus, all without any effort on your part. The Apollo wearable is designed to do just that. Created by neuroscientists and physicians, this innovative device uses gentle vibrations to activate your parasympathetic nervous system, helping you feel calmer, more focused, and better rested. Among the compelling reasons to use the Apollo wearable are that users experience a 40% reduction in stress and anxiety. Patients feel that they can sleep. Their sleep improves up to additional 30 minutes of sleep per night. It helps you to boost your focus and concentration. And it's scientifically backed. And the best part is you can get all these benefits with a special $40 discount by using the promo code Weitz, Weitz, my last name, at checkout to enjoy these savings. So go to Apollo Neuro and use the promo code Weitz today. And now back to our discussion. Yeah, you're a little more conservative than I am. I'm in sunny Southern California. People get a lot of sun. I still see a lot of people who are low, and they go to their primary care doctor and they have a 30 and they tell them, yep, that's good. And we know that's not good. So I usually start people on 5,000, sometimes go to 10,000. Sometimes somebody will shoot up to 90 or 100 and we'll back it off. But I often find that they have a recommendation to take 1,000. And my experience, that usually doesn't move the needle very much.
Well, even though you live in Southern California, a lot of people use the sunscreen, really latch on.
Sure.
And they wear a big hat, which I'm not against. I'm just saying,
right,
but they're not getting the benefit from the sun at all. So.
Right. And your body converts cholesterol into vitamin D. So if you're taking cholesterol lowering medication, you're going to be less likely to produce vitamin D as well.
Right. What else do I do? I usually do
hormones, thyroid.
Yep. And like on thyroid, I look at the TSH, and a lot of people are on too high a doses. If they have hypothyroid and they're put on some medication, Levo or whatever, and their TSH is driven down below 0.5, it can really affect their bone density.
Even 0.5 is kind of low.
Even 0.5 is a low, but typically you can get away with that, maybe even 0.4, but certainly not 0.3, 0.2, 0.1. And then anything above 5.5, 6.0, then I start getting nervous the other way. There's actually TSH receptors on osteoblasts. So you need TSH to stimulate those osteoblasts.
Not T3, you need TSH?
You need the TSH. Yeah.
Interesting. We got male and female hormones.
The hormones need to be there. For women, I'm very positive on recommending hormone replacement therapy in women over, into menopause. And I like to see their estradiol levels somewhere between 25 and 35, maybe 40 max, but they can do that with HRT, with hormone replacement therapy. For males, it's really important to have that testosterone and looking at the free testosterone and their sex hormone binding globulin. Sometimes their SHBG is so high that, giving an estrogen for a woman or testosterone to a man isn't going to help as much because their sex hormone binding globulin is grabbing all that testosterone or estrogen, binding it up, and then you need the hormone in a free state to work, in a free state to do its job with the bone cells. But when it's all bound up with the SHBG, it doesn't. And a lot of women are too thin. If they're too thin, and anything below 127 pounds is considered a risk factor for osteoporosis. And if you have a person that's 5'8" and they're 105 pounds, that's a problem. And one of the reasons why it's a problem is not only it changes their hormone levels, but it also changes leptin. And leptin is produced by your fat cells. And when a person's too thin, they don't have the leptin in them. And that's a neurotransmitter from in the brain, and it's produced by fat cells. But it almost acts like a co-receptor, or it actually does, with the estrogen on the bone cells. So if a person is postmenopausal and they want to go on HRT, hormone replacement therapy, but they're really too thin and they don't have any leptin, that hormone replacement therapy won't work as well. So just having them gain 5 pounds can make that HRT work better. So, that's just another lab test that, we might want to get on somebody, but we might not, depending on the situation.
Great. So let's go into what do we do for people who have poor bone health? And let's start with exercise.
What
else? Go ahead.
One last lab test.
Sure. Yeah. We can talk more about labs. I also, you said something interesting in one of your discussions about low red blood cells being a factor.
That's one of the things I wanted to talk about.
Okay.
Just low red blood cells is not definitive, but it's a.
And by the way, labs are like, some labs say under 4, some labs say 4.2. So you're talking about really low, right?
I'm talking about below 4. Yeah.
Okay.
Yeah. Usually, if I see somebody at 4 or 4.1, I kind of look at that. But what happens is when a person has osteoporosis, their bone marrow can fill up with fat. I don't care how skinny you are subcutaneous wise, but you can have 0 subcutaneous fat, but in their bone marrow can fill up with fat.
Why does that happen?
It's a way they think, that we don't know exactly, but it's a way that the body is trying to get ready for disaster. So if, in times of plenty, we're good. In times of no food, we have one thing we need to do, and that is survive. And so the body stores that fat because the person doesn't have any subcutaneous fat. So the body's saying, geez, we got to store some food someplace so that if they're really desperate, if their body is really desperate and going to crash and die, we need to have some food, some nutrition. And that's why the body throws that fat into the bone marrow. And so that bone marrow is their savior, really, the fat in there. But the problem is that fat is, a lot of it is palmitic acid, and it's poisonous to osteoblasts. Number one, so the osteoblasts can't work well when you have all that fat there. But number two, it crowds out the mesenchymal stem cells that produce your osteoblasts. So we can't have good bone cell formation when we have all that fat in there. And it crowds out the cells that make the red blood cells too, the hematopoietic stem cells. And that's why we don't have red blood cells. That's why the person's red blood cell count in their CBC goes down, because there's so much fat in the bone marrow. So yes, and for a cheap $5 test, that comprehensive metabolic profile can give you a lot of information. In my book, I go through all the different things on that CBC, and it really is for $5. It's a really important, but you need to know how to look at it.
Right.
And I want to back up a little bit and talk about that. I know I'm going all over the place, but
that's okay.
I get incredibly excited about the subject of lab tests because you can do so much for a person, help a person so much by doing it.
I love labs too.
But when we go back to the whole thing of perfusion, of making sure the person has good blood flow to an area, if a person has preclinical cardiovascular disease, that you need to look at that too. And a nice test that I like to do is called ADMA, or asymmetric dimethylarginine. And that is a really nice, simple, not that expensive test for looking at the onset of cardiovascular disease. So we want to, because you can do stuff about that. And if we can do stuff about that, then we know that we're going to prevent disaster 5 years, 10 years down the road for a person.
Yeah, that's measuring nitric oxide, right?
Right. Yeah. Yeah.
Which is crucial for the health of the endothelium. And then there are specific supplements that can help stimulate nitric oxide production.
Yes. And so we want to get ahead of this whole game, and not only for your whole body, but, for me, specifically for a person's bones. So.
Right. Small dense LDL, oxidized LDL, those are also things that are telling us that you're not going to be getting proper blood flow.
Right. So you ask about the exercise. Yes, you can do, all the nutrition you want, but exercise is vital to this whole game. And the exercise stimulates your muscles. Your muscles release myokines, they're little signaling molecules to the bones to say, hey, you guys are still needed. You bones, you're still needed, so you better do your job and be strong, because me, the muscle, needs you to be strong, because if you're working a muscle, then that bone is being put under stress a lot more. And so they need to step up to the plate and do their job to make that bone healthy and strong. So working your muscles does that, just from the muscle bone connection. But there's also that when you put stress on a bone, you then stimulate these bone cells to do their job too. So they're getting the message in two ways. They're getting it from the muscles, and they're getting it directly by the stress and strain that a bone is put under when you do exercise.
When it comes to exercise, I think a lot of people are confused about what is really needed to strengthen your bones. And I talk to a lot of patients who say, well, I walk, I go for a walk, I use these 2-pound dumbbells. And the reality is, studies that look at exercise is pretty clear that that's better than doing nothing, but that's not really going to put stress on your bones. Yeah. There haven't been that many studies that have really shown increases in bone density and decrease in fracture risk. And one of the few sets of studies that have are the Lift More trial in Australia. And those use heavy weight training. We're talking about deadlifts, squats, overhead presses with 5-rep maximum. We're not talking about 2-pound dumbbells.
Well, they use 85% of 1 RM, which is 85% of 1 rep maximum. And yes, it's crazy. I have patients, these little bitty women, and they're squatting 100 pounds and they're deadlifting 130 pounds. And I go, oh my God, because it is amazing to me. And the study you're talking about, the Lift More study out of Australia, and Belinda Beck was the main researcher from that. And yes, she showed that it does improve bone density and bone quality by doing these exercises. So now,
and they have an element of ballistic impact training.
Yes, they do that. They mostly do like heel drops and things like that.
Well, they have them jump up to a pull-up bar and then drop down.
Yeah. But that's when you talk about high intensity and impact training, that's what it's called. That's the impact part of it. When they do stuff. Right. So, they're now starting an Onero program, and there's several Onero programs, probably 10 of them now in the United States. So you can go to this, the bone clinic's website. It's called www.onero.academy.com, onero.academy.com, and they have a map of the world there, and they show on there where all these Onero programs are in the world. Most are in Australia, some in New Zealand and different around the world, but there are about 10 of them in the United States, and those are really good programs for people to join and get proper training and guidance by physical therapists who, it's really important to, when you're starting to do these intense exercises, you better have somebody watching you and not doing it on your own, but watching you to make sure you're doing them correctly. And that's what makes it safe. It's not safe to do this stuff on your own and just hope for the best. I think it is easy to get hurt. But that's what's so great about these Onero programs. It helps guide people.
What do you think about OsteoStrong?
I'm not a big fan. I've had several people get some fractures from it. Whether it helps or not, I don't want to say it does or doesn't. The research is minimal. It may help. I don't know, but I do caution people if they do it that to just be careful, and because I have seen some injuries on that.
Do you like vibration plates?
I think vibration plates have a place for sure. It doesn't take the place of exercise, but it's certainly an add-on, and it's certainly it does improve, especially if you do it 2 or 3 times a day. And you don't have to do it 20 minutes, but even if you did it for like 10 minutes, 10 minutes and 10 minutes, or 10 minutes and 5 minutes or something like that, but you're trying to stimulate bones and then relax, and then stimulate the bones and then relax. But yes, I think that the vibration plates, especially the Meridian, is a good choice. And Clinton Rubin is the main researcher on that, and I think he's really shown that it does work. It's not a miracle for sure, but there's a lot of people who can't go to the gym. They have some issue. They have multiple sclerosis or something to where they can't do the exercise that they need to do, and they're perfect for the vibration plate is perfect for them. But even people who are capable and can go to the gym, I think they would benefit from the vibration plate also. If they have that time and the finances to do that, I think it's a good choice. Yes. Yeah,
I used the vibration plate early on in my rehab when I was still on using a crutch and stuff, and I wasn't able to do squats and deadlifts yet.
Yeah. Perfect.
So let's talk about diet for bone health. Mm-hmm. Some people advocate an alkaline diet so that calcium won't be leached out of the bones to balance the blood pH. And some people have advocated a vegetarian diet. But I know you're also a big believer in getting adequate quality protein.
The protein I put as number one. You really need minimum. You take your weight, divide it in half and get a number. And that's the minimum. So if I'm 150 pounds, 75 grams a day. But, I try to get 75, 80, 90 grams a day. I honestly think, and I don't know why I have osteoporosis completely. I am gluten sensitive. But for me, I do think that, I was a really hardcore athlete for many, many, many years. And I guess still am. But I know that I didn't get the protein, and I know that was part of my problem. And I see so many people with getting 40 grams or 35 grams a day of protein, and that is just not enough. So yes.
Now you were basically an endurance type athlete, right? And you still do endurance events, correct?
Yeah. Yes, I do.
Now haven't endurance exercise been associated with bone density problems?
It is, and the reason why is because you're flooding your body with pro-inflammatory cytokines. You're flooding your body with oxidative stress that, you're really stressing the body tremendously. And it's hard to get all that nutrition. And athletes tend to push the carbohydrates and not the protein. So I think there's lots of reasons for that. And the loss of weight, the thinness, I now know leptin in women, or marginally, or 1 or 2, 3 level of leptin in women. So it changes their hormones a lot. So there's lots of reasons why endurance athletics can cause people to get osteoporosis. It doesn't mean that endurance activity is wrong, that you shouldn't do it. I'm just saying you better be aware that there's issues and you need to do it properly. You need to be really proactive on how to prevent that. And one of the ways is the protein intake.
And the best way to get protein, quality protein, is with animal protein, correct?
I think it's really difficult for people. We are not vegetarians, genetically speaking. We are omnivores. And, we're not herbivores, we're omnivores. And so I do think it's difficult as a vegetarian to get that protein. And yes, I think you can get from both. You get from vegetable matter and from meat sources. But yeah, I think it is important to do both. I think people can do it, but it's pretty difficult to do it as a vegetarian.
But it is important to try to have a lot of vegetables and fruits and things that are going to make sure our diet is more on an alkaline side, right?
Yes, I think if you eat just meat and potatoes all day long, you're gonna be acidic. And yes, it's your green vegetables that give you the 4 minerals that really help alkalize you are calcium, magnesium, sodium, bioorganic sodium, not salt, not sodium chloride, but sodium. And so what did I just say? Calcium, magnesium, sodium, and potassium. So potassium is probably the number 1. So in your bones, you have your calcium, magnesium. On the outside of your bones, you have potassium and sodium. And that's in what's called a hydration membrane. And the first thing that your body does when it becomes acidic, and when I say acidic, anything below 7 on the pH scale is acidic. But even if it gets to 7.3, 7.25, if your blood gets to 7.25, your body goes, oh, I don't like this. And that's, it's wanting to change that. It's wanting to bring your blood pH back up to 7.3 or 7.4. And the first way it does that is it taps that hydration membrane around bones for the potassium and the sodium to buffer those hydrogen ions, and hydrogen ions are the acidic ions in your body. So the body goes to the hydration membranes, gets that potassium, sodium, alkalizes the blood. And if it's not there, if you haven't been eating your veggies and your fruits, then it signals your parathyroid glands in your throat to pump out parathormone. That stimulates the osteoclast to break down bone. And now we can mine that calcium and magnesium in the bone to buffer those hydrogen ions.
So maybe throw some green powder in with your protein powder, and maybe throw in some collagen as well, right?
Well, I take almost every morning, I get this huge handful of greens, all kinds of different greens. I stuff them in my bullet blender. I put in my protein powder, and I grind it up, and that's pretty much my breakfast. So lots of greens and lots of protein.
Right. What about dairy?
I think it's fine to have dairy if you're not sensitive to it. Obviously, if you're sensitive to dairy or gluten or eggs or soy or anything, you shouldn't be taking it. But if you're not sensitive to dairy, it's fine to use dairy. I wouldn't use a lot of dairy. I think it's acidic in general, has a lot of phosphorus in it. So I wouldn't recommend people saying, drink 3 glasses of milk for your calcium. I don't think that's a wise thing to do. But some dairy is fine.
Are there forms of dairy are better? Like is yogurt better than milk?
I like kefir because kefir is even better than yogurt because not only does kefir have calcium, has protein and probiotics to help your gut health. So I'm a big kefir fan, and you can get kefir doesn't have sugar in it. And so I all times get blueberries or raspberries or something, and I pour kefir on it, and that's my dessert.
Okay, cool. What do you think about soy? Soy contains isoflavones that have been associated with bone health.
I think soy has gotten a bad name, and because there are people who have sensitivity to it. So yes, if you're sensitive, don't take it. But otherwise, I think soy is a great protein product, and with it, like you said, the isoflavones that do seem to help some people help stimulate the osteoblasts.
So let's talk about nutraceuticals, and let's start with calcium.
I always kind of recommend people take about 500 to 600 milligrams a day because you're going to get 700, 800 from your diet.
So you want to get, say, 1,200 total between diet and supplements?
Yep. And for magnesium, 300 to 400 probably. I recommend that from your supplements because it is hard to get magnesium in your diet. But so I always encourage people to get 300 to 400 in addition as a supplement, and not magnesium oxide, but I think the magnesium malate chelate, magnesium bisglycinate, magnesium citrate, magnesium tartrate, they're all fine, but I just try to steer people away from the magnesium oxide as I don't think you absorb as much of that. And with
what form of calcium do you like?
Anything. It doesn't matter to me except not calcium carbonate. But once again, calcium malate chelate I think is the best. Calcium bisglycinate, calcium citrate, but also the microcrystalline hydroxyapatite, the MCHA. I think that's a good form. It's a little bit less absorbed than the calcium malate chelate, but the MCHA, like I said, microcrystalline hydroxyapatite from bone, is a good form of calcium too.
Now, some people are freaked out about consuming calcium because there's been some studies linking calcium supplementation with the risk of atherosclerosis, even with the risk of arrhythmia. And I know in your book, you compare the overreaction to these studies to the overreaction to the Women's Health Initiative studies when all the doctors stopped prescribing hormones. So a lot of people are afraid to take calcium because of this, and doctors are not sure what to do. And you have cardiologists out there telling patients, don't ever take calcium.
Right. Yeah, I think they're doing a disservice to people. And as you say, it's exactly what happened in 2001 with the Women's Health Initiative when that came out, and with oral 0.625 estradiol was given and came up with a slight risk in cardiovascular disease and all that. And so all the doctors said, no more estrogen for women. And that was a great disservice. And I think the same thing's happening with this calcium. And no, I don't think people should take 1,200 and 2,000 milligrams of supplemental calcium every day. I don't think that. I do think that that's a problem. But when you say no supplemental calcium and a person doesn't eat dairy, they're not going to get 1,000 or 1,200 milligrams of calcium. So you need to take supplemental calcium, and I recommend not taking 500 all at once, but taking 150 or 200 with each meal, making sure you chew it up slightly in your mouth, taste it a little bit. That neurologically signals your brain that it's coming. It acts more like food. It gets your body prepared for it. You're not spiking your blood calcium that way by taking these small doses, and you're hedging your bets and saying, okay, I'm covering my bases, and I know I'm going to get my 1,000 or 1,200 because I don't eat dairy, maybe, or I don't eat sardines, or I don't eat sesame. If your diet is low in calcium, you need to take supplemental calcium.
And if that calcium is being consumed with the right amount of vitamin D and the right amount of vitamin K, it's going to be utilized and not end up in the arteries.
That's right. And that's an incredibly important point. That, yeah, if you're just taking calcium and not the magnesium, not the K, not the D, not the trace minerals, then that's not balanced, and that is probably a problem.
And you point out in your book, not only did subsequent studies looking at whether there's a correlation between calcium and atherosclerosis really show that there was a correlation, but there's actually more of a correlation between osteoporosis and arterial plaque.
Yes. And, you can make a case for anything. And I think what happens with the media is they like to make a story out of something. And I think that's what happened with the studies that came out 10 years ago with the calcium. Is the media jumped on it and said, wow, we never thought that calcium could be a big story, that it would be detrimental to your health. And the media just jumped on it and made more out of it than they should have.
So vitamin K is super important. And I have recently become convinced that the MK4 form at a higher dosage is probably the most beneficial, especially for osteoporosis. So I've started recommending the 45 milligrams of MK4. What do you think about vitamin K, and what form and how much do you like?
There's two forms of vitamin K2. There's MK4 or menaquinone 4,
right,
and MK7. The MK7 lasts longer in your blood, probably a day and a half or so half-life. The MK4 is much less of a half-life. Even though these are fat-soluble vitamins, they don't last long in your blood. So the MK4 only lasts, has a half-life of 3 to 4 hours in your blood. So that's why I think it's good to take a combination of the two. But you're right. I really think that the MK4 is the more important of the two. And I've seen people get heart palpitations when they take too much of the K2 MK7. And to me, that's probably, more than 100 micrograms I wouldn't take. I would take between 50 and 100 micrograms of K2 MK7. For the K2 MK4, I usually recommend 500 to 1,000, although maybe up to 5,000 or 5 milligrams can do a little bit better job than the 500 to 1,000. I'm not sure it does a lot more. And I don't think the 45 milligrams is harmful to anybody. I think lots of people do that. There's been several studies on that. It doesn't show that it hurts anybody. Does it actually help? I'm not sure it does. But for sure, up to 5 milligrams a day is perfectly fine and probably helps a person more. You have to understand what the vitamin K does, and it is incredibly important for bone health. When your osteoblasts are forming bone, they pump out this protein called osteocalcin. And osteocalcin needs to be activated or carboxylated by vitamin K. That's the magic. So the osteoblasts might form the osteocalcin, but if that vitamin K is not there to activate that osteocalcin, you're not going to get a bone crystal formation. So that vitamin K has to kind of be there 24/7. And that's why it's important to take that, if a person has low bone density, they should be taking vitamin K every day.
What do you think about strontium citrate?
I'm a little negative on strontium.
Okay.
In my book, I write about 2 pages about it because I am not that passionate about it. I'm passionate about it negatively instead of positively. And the reason why, I have a real reason that is important to look at that most people don't. And that is, number one, all the research for strontium, or most of the research out there, has been on strontium renylate from Europe. And that strontium renylate was taken off the market. And now we can only get, well, actually, they put it back on the market but you can still only get it in Europe. In the United States, we can only get the strontium salts, and a lot of people talk about strontium and they cite the research for strontium, but that research they're citing is from strontium renylate, not from a strontium salt. And I don't think we can do that. I don't think there's research that really shows that, yes, strontium does improve bone density. No doubt about it. It does improve bone density, but does it decrease fracture risk? We don't know that. But I go even further than that. And my big beef is, if you stop strontium, let's say you take strontium for three years, and then you kind of lose interest, or for whatever reason you stop strontium. My concern is that strontium molecule that strontium atom leaves the bone crystal quicker than calcium, and may leave that bone crystal in a different state that makes it more vulnerable to fracture, that makes that bone more vulnerable to fracture. It's because of the rapidness for which those bone crystals lose that strontium, unlike the pace that calcium is lost from a bone crystal. Strontium is lost much faster and can change the strength of that bone crystal itself. So if you start strontium, I encourage people to stay on it. If they've been on it for 3 months, it doesn't matter. But if they've been on it for 3 years, then I think people needs to stay on it then.
Another controversial mineral is fluoride.
You don't want to be doing that. Certainly make your bones more fragile.
Okay, that's where I'm at with that.
Yeah.
One of my favorite nutraceuticals for so many things that I've been taking for years is berberine. And you talk about some of the bone effects, how it stimulates osteoblast formation. That's a new one for me. So that's pretty fascinating.
I really recommend berberine in not high doses, but 250 milligrams or so. But it stimulates the osteoblast, and it's a cool herb because it calms down the osteoclast, yet stimulates the osteoblast. And it's good for your gut in general. And your gut health is number one for improving bone health, because in your gut is 70% of your immune system. And so you need that gut to not only be able to absorb things properly, but to not be rallying up your immune system, which is then going to rally up the osteoclast. So yeah, berberine's great for helping lots of things.
Yeah, I know you like to look at gut health and even do a stool test and make sure you get that gut improved as part of the program.
Yes. Yeah. If a person has a gut issue, there's a lot of great stool tests out there to do. I happen to like the Diagnostic Solutions GI Map, but there's other ones that are good too, but that's the one I use. So.
Just did an interview with Tom Fabian this morning talking about the GI Map.
That's a good tool to use. Yeah.
Yeah, I like the GI Map as well. So now let's go into the pharmaceutical medications for osteoporosis.
There's not very many. There's only about 10 medications, really. We'll talk about, so there's 4 bisphosphonates, and like I said, there's only really 5 that are anti-resorptive. So there's 4 bisphosphonates. There's Fosamax, Actonel, Beniva, and Reclast. And they are called anti-resorptives because that's what they do. They stop those osteoclasts from tearing down bone. They stop that resorption by the osteoclast. They don't add bone quality to somebody's bones. They just decrease bone loss and allow a sprinkling in of calcium into that bone. So it makes the bone harder. It doesn't make the bone quality better. It makes the bone density higher. And remember, bone strength is a combination of bone density and bone quality. And the bisphosphonates only add bone density to that bone. And then there's the
one of the problems potentially with these drugs is by blocking that osteoclastic activity, which is essentially the cleaning crew that cleans up the bits of bone that get damaged from normal activity, is you are likely to get an increased accumulation of less healthy bone.
The microfractures, you're right.
Right.
If you do bisphosphonate for a year or two, that's fine. It's not going to hurt you. What's going to hurt you is to be on it for 3, 4, 5, 6 years. Then you're right. Then these microfractures.
I talk to patients who are on it for 15, 20 years.
To me, that's awful. Yeah, it's really sad. And because they have built up microfractures in there. Not only that, is when they exercise, the exercise doesn't do them nearly as much good as if they had, a bone turnover. Because if you have viable osteoclasts and blasts, then they can respond to that exercise that you're doing. So that fifth one, the anti-resorptive, is Prolia. Prolia has lots of issues. I do recommend it sometimes, though, and a person might need Prolia, especially if their hips are very, very low bone density, because Prolia does do a way better job on hip bone density than a bisphosphonate does. So Prolia does have its place. Even though I push and encourage nutrition and supplements and exercise, I'm not against medications. What I'm against is when people use medications, number one, solely as their treatment for osteoporosis, and number two, when they use them long term. Medications can really help people get a person out of trouble, but you usually only have to use a medication for 2 or 3 years, and then you're done. And then you rely solely on the nutrition and supplements and stuff. And sometimes people don't need a medication at all, but sometimes it can be a lifesaver.
So for patients who are afraid to stop taking their medication, what you're saying is, if you're taking an anti-resorptive drug like a bisphosphonate, after 2 or 3 years, you're not getting much benefit out of it.
You're not, and you may have to go back on it in the future if, depending on, we're going to look at bone turnover markers and stuff, but it's that long-term use of it backfires, and then the bone can become, like we said, just much more vulnerable to breaking. Atypical femur fractures or osteonecrosis of the jaw or something like that. But short-term use is okay. And remember, all during that time of short-term use, what are we doing to that person? We're improving their whole body through changing their nutrition, changing their supplements, having them exercise more. So we're kind of getting them ready, getting their body ready to be able to go drug-free in the future. So it's a way to buy time too. Personally.
And then we have the anabolic medications.
Anabolics, and there's only 3 anabolics, and that's Forteo or teriparatide and Tymlos or abloparatide, and then there's Evenity or romosozumab. And the Forteo and the Tymlos are pretty similar. They're analogs of parathyroid hormone, and then the Evenity or the romosozumab, that's an antibody against sclerostin. Sclerostin is this protein that's produced by your osteocytes that shuts down or tempers osteoblastic activity. So your body doesn't want to have osteoporosis, and it doesn't want to have osteopetrosis either. Petrosis is too hard of bones, too thick of bones. And that's what would happen if your osteoblasts were allowed to just run amok and just build tons and tons of bone. So your body produces this sclerostin to bring back that osteoblastic activity. So the Evenity is an antibody against that sclerostin. It gets rid of that sclerostin for a year, because that's how long the Evenity is given. And during that whole year, those osteoblasts can go wild and crazy and just build lots and lots of bone. So you can actually get 12 to 14% of bone in 1 year by taking Evenity. For the Forteo and Tymlos, you can get 8 to 10% in about a year and a half. Well, year and a half, 2 years. So they both, Forteo or Tymlos and Evenity, they're great anabolic drugs that can really add bone quality and bone density to somebody.
But it can be difficult to get insurance to want to cover these medications because they're expensive.
Yeah.
And in your book, you actually talk about how ideally there's a lot of patients would benefit from starting with an anabolic medication, building up some more bone, and then following it with a Prolia or a bisphosphonate so you can hold on to those gains.
Right.
But insurance often doesn't want to pay for the anabolic medication simply because it's more expensive. So they force the patient to take a bisphosphonate to start with. And then if you do that and then you do an anabolic medication because the bisphosphonate has failed, it's going to be less effective.
Unfortunately, that's a true situation. And it's unfortunate because you're right. The anabolics don't work as well if you take the anti-resorptive first. So, and the anabolics, you have to follow them all with an anti-resorptive because there can be what's called a rebound effect. The same with Prolia. You have to follow Prolia up with reclass or zoledronic acid so there's no rebound. But yes, if a person's bone density is really poor and their quality is poor, they need to do an anabolic first and then follow it up with an anti-resorptive and not the other way around.
So I see ads now where they're recommending Evenity followed by Prolia. Does it need to be Evenity, then Prolia, then reclassed?
That all comes down to a person's hip, in my opinion.
Okay.
So let's say a person's hip is a negative 3.6 and their spine's a negative 4.8. They need a medication. And Evenity would be great for that because Evenity is going to help that hip way more than Forteo or Tymlos. If the hip is, a negative 2.8, Forteo and Tymlos are perfectly great drugs to help that spine because they're not going to help the hip as much. But if the hip is really poor, like I said, negative 3.7, 3.8, or even 3.5, 3.6, and the Evenity only improves them to maybe a negative 3.4, then yes, I would say Prolia would be a better choice than doing reclass. And you might do that Prolia for like 2 years and then the reclass after. You have to follow up Prolia with reclass. And one of my pet peeves is seeing people on Prolia for 3, 4, 5, 6, 7 years, because it can be incredibly difficult to get them off of Prolia and not have a rebound. And I talk about that at length in my book and how awful of a situation that is. I've just seen way too many people who have been put on Prolia and then they've stopped Prolia and they have a huge rebound. And within 3 or 4 months, they're fracturing like 5, 6, 7, 8 vertebrae. Just their spine just starts crumbling.
Wow. So that's pretty scary. People listening to this are probably thinking, I don't want to go on that Prolia.
Well, if you do, it has to be done properly. And unfortunately, some doctors don't know how to do it properly.
But you don't want to just take Evenity and not follow it with something, right?
No, all the anabolics you need to follow it with at least a year of something, of an anti-resorptive of some kind. Yeah.
Just because you won't hold on to those gains and you'll have like.
So Evenity is a very interesting drug. It acts as an anabolic for the first 8 months and then as an anti-resorptive for the next 4 months, about that. And it's still, you can have, when you stop Evenity, there can still be a bit of a rebound. Even though it becomes an anti-resorptive, you can still have a rebound and actually lose some density. And we want to solidify that. We want to cement that bone density and bone quality in there. So by taking a bisphosphonate, you're ensuring that those osteoclasts don't start ramping up and breaking down that bone again.
Okay, great. This was a tour de force discussion of bone health. Thank you so much, Dr. McCormick.
I love talking about this, as you can tell. I'm pretty passionate about it. So
absolutely. So everybody should pick up Great Bones. It's available through Amazon, right?
Yep.
And if people want to work with you, are you still available?
Yeah, I do either telephone consults or in person. It doesn't matter. So
how do they get a hold of you?
You can go to my website. I actually have a brand new website. I'm trying to think of the name of it. It just went up like 3 days ago.
Okay.
www.greatbonesconsulting.com. So,
okay.
But yeah, that's sort of, you have to do the HTTPS.
Yeah. Everybody knows that. Yep.
Yeah. But greatbonesconsulting.com, or you can just put in Keith McCormick. I don't know if you would come up with it that way anymore. I'm a little bit flux with this new website and how it works, but
it looks like your old website's still up there.
Is it? Okay.
That's what I looked at. I didn't see the new website.
This is all happening this week. So
all right.
What's going on? But yes, they can go to just Keith McCormick and Keith McCormick DC and www. Or my supplement company, which is osteonaturals.com. And you can get to my website that way too. So either osteonaturals.com or keithmccormick.com.
And practitioners, can they distribute your supplements? Is that something?
Yeah, we have programs where they can do that.
They can become a professional distributor.
Yeah.
Okay. That's great. Thank you so much.
You're welcome. Thanks for having me on, Dr. Weitz.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.